Welcome to the Center of Excellence for Behavioral Health in Nursing Facilities virtual education event. Today's session will cover an introduction to creating a trauma-informed culture in the post-acute and long-term care facility, part 2. My name is Michelle Wilker, and I am the technical support for today's session. We have just a few housekeeping items as we get started. If you haven't already, please complete the pre-test survey. You can click the link in the chat or scan the QR code to complete the survey. This session is being recorded. All lines are muted. If you have a question during the session, please place it in the chat. This session is scheduled for 60 minutes. We will have a question and answer session at the end where you can again place your question in the chat, or you can raise your hand. When prompted to do so, please unmute your microphone and state your question or comment. Next slide, please. So again, we welcome you to today's session. As we near the end of the webinar, there will be a post-test survey that we would like you to complete as well. We thank you in advance for your time and your participation. Now I will give the floor to your host, Nikki Harris. Next slide, please.
Good afternoon and welcome. I am Nikki Harris, Training and Education Lead for the Center of Excellence for Behavioral Health in Nursing Facilities, and it is my pleasure to oversee the delivery of mental health and substance use disorder training and education to nursing facilities nationally at no cost to the nursing facility. Thank you for attending our training today. If you are attending the training in a group setting and did not register, we ask that you please place your name, organization, and email in the chat, please. And now, I am happy to introduce to you today our presenter. Today's presenter is Paige Hector. Paige is a consultant, nationally recognized speaker, and author with over 25 years of experience in post-acute and long-term care settings. She specializes in diverse topics for the interdisciplinary team, person-centered care, trauma, informed care, nonviolent communication, sustainable process improvement, and adverse care planning. Paige writes extensively on topics relevant to nursing homes, including multiple chapters of Managing the Long-Term Care Facility, 2nd edition, due for publication in 2023. Paige is currently the associate editor and a regular columnist for the Caring for the Ages, the publication for AMDA, the Society for Post-Acute and Long-Term Care Medicine. In 2018, she was named the Gerontologist of the Year for Arizona Geriatrics Society. And now, Paige Hector. Thank you, Paige.
Hello, everyone. Nice to be here again. This is part 2 of our training series, an introduction to creating a trauma-informed culture. Today, we're going to be talking about trauma-informed principles, behaviors, and you'll notice the quotations, and that'll become clear why I've done that, and the impact of an activated nervous system. Here's the objectives for today. We're going to be talking about the principles and how a trauma-informed culture supports residents as well as staff. I'll bring up a little bit more information about triggers and how they impact a person's behavior. And then we're going to spend a chunk of time on the nervous system and how it responds when we perceive a threat and why that information is so important for all of us to integrate into all of our interactions with residents as well as one another. So let's do a quick recap of what we covered in part 1. We covered definitions of trauma, sources and impacts, reactions and not behaviors and the difference, and I'll touch briefly on that information again. The idea that trauma is cumulative, that it's not just a point in time or one spot or one event, but that it's cumulative over a lifetime of experience. So something that happened as a very young child can impact a person well into their 80s, 90s, and even older. There was a delayed reaction to trauma worksheet that's available for your use. We talked about triggers and re-traumatization and the idea that becoming a trauma-informed community is a continual process. It's not an endpoint. It's not like we're going to complete this project on this date. It's It's ongoing and truly never ending. So this is a quotation that just really sets the tone. Even before the relentless stress of the pandemic, trauma was recognized as a widespread, harmful, and costly public health problem, addressing trauma an important component of effective behavioral health service delivery. So while I think the pandemic, when we think of trauma, that's probably one of the things that comes to at least many of our minds, this was something that was recognized well before 2019 when we first began experiencing the pandemic. This just was fascinating to me as well, that the estimate, you'll notice the date on this, I was not able to find more current data for 2023, for example. Every dollar spent on trauma-informed care saves $5 over the course of a lifetime of cost. Incredible to me. So to me, it was even more, not only is it trauma-informed care for the well-being of staff and residents, but it also saves us money, which is important. There's a perspective on time, and this is a slide that I use in a lot of my work, because I think a lot of us have this idea. I know I have said things like, I don't have enough time, there isn't enough time. That's a socialization, that's a product of how we are socialized and conditioned to think about time. It's called scarcity thinking, that we don't have enough, that there isn't enough. And what I want to propose to you, and this is something that's been very profound in my work over many years, is that we can switch how we think about time. So instead of saving time upfront and losing it later, the choice that we can be making, and I really think it comes into clarity with trauma-informed care, because the idea that there's no end point, it's not like a project we just start and finish. I wanted to give you guys some way of thinking about it and conceptualizing that the more that we spend upfront learning about implementing trauma-informed care principles for residents as well as staff, we actually will harvest the results later. So think about all the time that we spend on things like conflict resolution and complaints and other problems in that broad category. My belief and what I'm seeing happen is that the more that we spend on trauma-informed care on the front, I'm going to minimize some of those other activities that we spend time on later. To me, we start with staff. We start with all of you on this webinar today. It is my belief that until we implement trauma-informed care for staff, I just do not think it's possible, or at least maximally effective, to implement it for residents and for patients. So my focus, everything I do, is creating and teaching and learning about how do I bring these principles to life for the staff, who can then bring them to life for residents and patients in the environment. I want to acknowledge healthcare staff. I have no doubt all of you on this call today, no matter what position you hold, what job titles you have, that it's healthcare staff have a deep intention to care for other human beings. I mean, that's why we do this work that we do. We don't do it for the glamour or certainly not the money. We do it because we have this very deep intention to care for other human beings. Couple of statistics though. 4 out of 10 US employees strongly agree that their supervisor or someone at work seems to care about them as a person. That only 40% believe that someone seems to care about them as a person. 67% of employees are ready to quit, say leaders made empty promises for well-being. 41% say of employees are likely to quit to resolve stress because it's too much. 25% said that they are underperforming due to stress. So when I read these, now these were based in acute care. I do believe that they absolutely apply to post-acute and long-term care. So again, this was more impetus for me to even bring more focus on trauma-informed care and the well-being that can happen because of putting these principles into play. So here's the definition. This is how I define person, and I use person-centered trauma-informed care. It recognizes the pervasive nature of trauma and integrates principles and practices to promote healing and recovery. So it's not a thing to complete. There's no completion date. So what we're really looking at here is changing how we think, how we speak, and how we behave. Not too long ago, I read this great article. I'm sure many of you read McKnight's, and this was by Dr. Barbara. She wrote, I operate from a belief that virtually every resident coming into long-term care has been traumatized to at least some extent by the health event that precipitated their admission, the medical procedures they've undergone, being away from home, and other losses. While not every resident has post-traumatic stress disorder, for most people, this experience brings up past times when aspects of their lives were out of control. So again, right there, she speaks to the idea that trauma is cumulative. So this just really set the stage for me that there's so much trauma going on that we actually might have blinders on because it seems normal to us, especially in healthcare, when we have many people coming and going from our communities, that we may lose the perspective that what this one individual's experience could actually be very traumatic. Trauma-informed care is the practice of engaging others and providing care by intentionally considering, and I really highlighted those words here for a purpose. When we think about everything that a person might have gone through, we put the focus on the impact by intentionally considering how might those experiences be impacting the person in their current presentation. That's a very, very important aspect of trauma-informed care. All the things that might have happened in the past, we may or may not even know about them. But what we're doing is intentionally considering the impact of all those experiences on how the person is showing up right now, today, in our community. So trauma-informed care certainly is person-centered, hence my emphasis on person-centered trauma-informed care, PCTI. It's fundamental, it's integrative, it's a relational posture toward everyone. So everyone is involved, and it's a culture. So I want to disentangle a few things. Trauma-informed care is not just a training on PTSD. It is not just solely based on the medical model or just a prescribed protocol or a set of skills. It is not just for residents or just for people who actually do have PTSD. Trauma-informed care is a mindset. It's how we think and how we speak differently. It's putting the patient or resident, either word that works for you, in control of their environment. There's two questions here that I think are really great. What would make this visit feel healing for you? And what would help you feel like this is a place that you could come back to? For example, if the person's coming into your community for post-acute services, rehab, intensive nursing, something like that, where you anticipate that they might be discharged. So what would help this feel like a place that you could come back to? So we're getting a sense here of some of the questions that we might be able to ask to bring trauma-informed care to life. Some of you might have heard of of course, we've all heard of universal precautions, but I want to apply it to trauma-informed care. So of course, universal precautions are gloving and hand washing, no matter the level of hazard, right? We glove up and we hand wash. When we're talking about trauma, it's the idea that we universally glove up. We metaphorically are looking to reduce the possibility of triggering or re-traumatizing another person. So the idea here is that we maintain awareness that life experiences can have been shaped by trauma and adversity, which inform how a person behaves. In other words, how they show up, what they say, and what they do in the current situation. So when I can come to any situation, and this is with residents, with patients, with families, with one another, colleagues, and I can just kind of have this foundational perspective that everything that might be happening here with this person in the present moment could in fact be informed by their past experiences. So again, I keep coming back to this mindset shift from what is wrong with this person, which is really, really squarely based in a medical model, the traditional hierarchical medical model. What's wrong with this person? We've got diagnoses, we've got problem lists, to what is the impact of their past experiences on the current presentation. It's a very different perspective. So let's talk about the principles. Here they are. There are 6 recognized principles here of person-centered trauma-informed care. So I'm going to be going through each of these and give you some prompts of how to think about integrating these into your communities, or maybe even asking are these even present in my community? So when we think about safety, we tend to think about physical safety, that we want to have a physically safe plant. We've got security measures in place. We've done our disaster planning with policies and procedures. Absolutely important. Social safety is also a big part of that. So things that comprise or help us to have a sense of social safety is the ability to be part of a group, to listen, and to be heard. Folks, that is so, so important. A lot of times we tend to talk over and through and around one another. We get caught up in defending and explaining and educating and advising. So social safety is the idea of listening and being heard and acknowledged. The ability to play a role in conflict resolution and to serve a group process. Moral safety is an environment that integrates qualities including integrity, responsibility, honesty, tolerance, compassion, peace, and nonviolence. So when I think about staff and all the things that you all have been through over these years, there's been some research to show how the moral safety for healthcare workers has really been impacted severely in light of the pandemic. I wanted to add this little slide in here before we talk about trust and transparency. Creating an environment that's safe for staff includes a couple of really important things. The psychological safety, which is defined as the ability to trust one another, that your staff feels safe, for example, to admit that they've made a mistake, to ask a question, offer new data and ideas, and to try a new skill, and this is important, without the fear of embarrassment or punishment, that there's no shame. The second really important thing for staff safety is that we allow team members to learn, to teach, communicate, reason, and think, and all of these things that together help us achieve shared goals. So when I think about your culture, ask yourselves, do we really cultivate this sense of environment for staff? Trust and transparency. So trust is one of the most important trauma-informed care principles. So when we can create an environment that's built on safety and empowerment, people having a voice and having authentic choice, all of those qualities bring trust on board, that we come to people without having an agenda. We pay attention to their comfort, to their nonverbal communication, and we certainly uphold confidentiality and privacy. Transparency is that the organizational operations, that things are transparent, that there's a sense of predictability, that we do what we say we're going to do when we say we're going to do it, and that when things don't go according to plan, that's actually okay. What's really important with the idea of transparency, this principle, is that what do we do when things don't go according to plan? How do we communicate with people? How do we bring them in as part of the conflict, the resolution? So that's transparency. Empowerment, voice, and choice, that we recognize and we build on people's strengths. As a social worker, that's my training and background. And one of the principles that I bring to the table that I do believe a lot of staff do is that we focus on people's strengths, that every single resident in your community, all of you on this call, have strengths that we would want to look at, and how do we bring those in to create a trauma-informed culture? The idea that we support self-determination and advocacy. We give voice to people who have not had a say, that we are committed to shared decision-making and choice. And there's a very strong commitment and belief that healing and recovery is possible, a sense of hope. Peer support. This is one of this, we're on the fifth of 6 trauma-informed care principles. So there's support from people who share similar experiences. All of you on this call are actually doing something in terms of peer support. We're sharing this experience together, that you could call upon one another to help elevate and implement these principles in your own community. Connections like this help us feel like we're part of something, that we're collaborating, and that we're connected, Attention to cultural, historical, and gender issues. This is a very big category. And again, we could do hours and hours just on each one of these principles, but this is the self-awareness of the biases, the stigma, discriminations, and stereotypes that we actively try to address all of these. We incorporate policies and protocols and processes that are responsive. We generate a sense of cultural humility and curiosity. We honor healing value of cultural connections. And we address historical trauma. Now, this is one I wanted to spend a moment here. So historical trauma are events that are experienced by a collective community. I put several in as an example here. So the Holocaust, slavery, genocide, victimization, and oppression. So while the number of Holocaust survivors is dwindling as they get older and they die, the effect and the impact of that experience on their children and their grandchildren has actually been passed down genetically across many, many years. So even though you may not have a Holocaust survivor, you could have family members of Holocaust survivors. So the idea that trauma is passed on genetically is called epigenetics. So we want to be aware of these things. So slavery, genocide, victimization, all of these things can be present even if the person, him or herself, has never experienced them firsthand. Collaboration and mutuality, the idea that everyone has a role to play. So everyone, every staff member, every department, every role, every job description needs to be included in creating a trauma-informed care culture. There's an emphasis on partnering with people, true partnership with people, a meaningful sharing of power and decision-making, and that we level any power differences. So for example, supervisors to employees, staff to residents. I want to spend just a moment talking about power differences because this is crucially important to creating a trauma-informed care culture. The needs and the concerns and the dissent, in other words, when people do not agree, is dissent, of people with less power are less likely to be heard, to be on the table, to be considered. We are less likely to know what people with less power need because either one, they will not know, or they will not say it. Because when there's a power difference, it's very difficult to speak up. Think about yourself in your own life. When you know that there was a power difference, perhaps it's with your supervisors, your people above you in that hierarchical, because we all work in healthcare and that's kind of how it's set up. But it can also be in your past experience. You, as a student, a teacher or professor, as a child, a parent has hierarchy over. We are trained to not say anything about what we need or the impact, how the situation is impacting, how it's affecting us. We are socialized to not speak up and say how it's impacting us. So people with lesser power in our communities include people of the global majority. And what do I mean by that? The global majority are people of brown and black skin color. So the global majority is the numbers are actually much greater. So I'm very cautious about the languaging I use, and I will not use the term minority, because what we conceptualize when we use that term is actually more appropriately described as the global majority. Other people with less power include people living with disabilities, older people, and people with lower socioeconomic status. So all of these people are included. When I talk about people with less power, those are some 4 big categories. I just want to name something here as well. In healthcare, we have traditional healthcare, and I want to be very cautious here. I'm not implying that every single one of our facilities or communities always operates in a domination, hierarchical, structured format. So I think there's many places where there's probably a mixture, and I would love to believe that we're shifting more from a domination society perspective to one of true partnership. So some of the characteristics of a domination society or a medical community, there's power over. If you think about, we tend to, and I do believe it's changing, but traditionally, we tend to write orders. We tend to tell people what to do. Here's your job description. You are expected to follow these things. So it's very much a power over paradigm. There's a lot of hierarchy and control, obey. extrinsic needs, which are we reward people or we punish people. There's a lot of fear. There's devaluing. So our needs around caring and empathy may not be as strong in a domination society. In contrast, one of partnership is where we power with, which is what I just talked about. We level power differences. We are more authentic. We're able to say what's true for ourselves. We can speak up. There's more of safety, the social safety and moral safety. There's a lot more trust. We communicate to connect with other people, not to manipulate them. Caring and empathy are highly valued in a partnership. So this is ongoing. It's never ending. So truly trauma-informed certainly is over here in a paradigm of partnership. So let me just segue in, and I want to just briefly mention, we did talk about triggers, and that'll be very clear why I'm bringing this very important content up again. Triggers. So if you think back to the FTAG 699, it talks about learning about people's triggers to avoid re-traumatization. So triggers are reminders of dangerous or frightening things or people that happened in the past. And I'm very clear to say that the past could be yesterday, it could be 80 years ago. So it could be at any point in time. The person is experiencing that event as though it's happening all over again, even if the current environment is safe. That's where it gets really hard for people to be witness to someone who's having a reaction to something, and it's very puzzling or confusing because that person's nervous system is actually experiencing something that other people may not understand or they're not experiencing. Triggers can come without warning and literally be anything at all, absolutely anything. When a person is triggered, and this is any of us, folks, this is not just residents or patients, it's all of us on this call today. Trauma reminders can be interpreted as, I am not safe, I cannot protect myself, I could die, or I don't matter. Now, I added that last one on there, I don't matter. When we do not believe as human beings that our mattering, that our needs matter, that actually can trigger a stress response in our nervous system. If I don't matter, I don't belong, I'm not included, I'm not known, I'm not understood, I'm not valued. So that can be a very threatening experience. So that leads me to talk a little bit about behaviors. I started thinking to myself, you know, for years, I've been doing healthcare work in nursing homes, or it's coming up now on 30 years. And I've been taught, we've been conditioned in healthcare that if I say to any of you on this call, oh, that person's having behaviors, you all are going to know what I'm talking about, at least in a general sense. I would really love to untangle this. Behavior descriptions, for example, if I say to you they're having behaviors, automatically that stimulates for you, oh, they're wrong, bad, or inappropriate behaviors, difficult behaviors. We might have behavior monitoring and behavior tracking. We have behavior care plans and we have behavior management. So if we tease out a little bit, what exactly is behavior? I get really curious about words and language, so I love to look things up. So I got the dictionary going. There's some definitions here of behavior. It's the way in which we act or conduct ourselves. The actions or reactions of someone in response to an external or something internal, something that happens on the inside of a stimulus. It's an observation. So when I say behavior, it's something that I can hear or I can see another person or myself doing. What I want to disentangle here, so if you think back to the slide that I just showed you, in a domination society, we categorize things as either or. It's this or it's that. It's good or bad. It's right or wrong. It's appropriate or inappropriate. So if we could take away those judgments around behavior, that it's good, bad, positive, negative, appropriate, inappropriate, we could drop all of that, just let it go and understand instead. This is such fun here, this last bullet point, that everything that a human being does and says is an attempt to meet their needs. That's what behavior is. I'm speaking right now because I have a need to teach, a need to contribute, to collaborate, a shared learning environment. So I'm actually having a behavior at this moment. So what do we do instead? If we're not going to call them behaviors, we've got to have some language, right? We need to have a language. They're reactions. They are reactions that contribute to challenging or difficult because they can be very challenging. I listed several here, and I have zero doubt that together we could make multiple slides with multiple reactions, things that can be really challenging to work with in healthcare settings. Let me put this in a trauma-informed care perspective. These are probably coping mechanisms that at the time when there was a traumatic or stressful event or experience, when a person was experiencing that, they might have yelled or argued or isolated or withdrawn or had protective gestures where they protect themselves. They could have resisted, declined. They could do things like explore pain relieving things with drugs or alcohol, unwelcome sexual expression. All of these things, folks, could be coping mechanisms that made perfect sense at the time of the traumatic experience, even though they no longer serve or suit the current circumstance or situation. If you're not familiar with Gabor Mate, an incredible book, The Myth of Normal is his most recent book. He says that they are not character faults, and while they may cause us difficulty now, they began as modes of survival. That is so incredibly important that we understand that a lot of the things that we think of as challenging or difficult in our nursing homes and assisted living communities, that they actually began as coping mechanisms in response to a stimulus. So let's talk about nervous system response. This is one of my favorite topics to talk about because I think as we begin to understand and think about how you can communicate this information to all the staff in your community. Okay. Is it a stick or is it a snake? So I live in Arizona, so this is a very real thing for me. When I walk early in the morning or when I'm out walking my dog, I'm very attuned to what's going on around me for the purpose of being protective and not stepping on a snake. We receive input from the environment and we do not have control over what our brain. So when I first put this slide up to you, you probably had a reaction. Oof, you could have thought it was a stick or a snake, and you don't have control over what your brain says. If there was any sort of a threat, your brain determined, oh, this is dangerous. There's something going on. The perception, if it was one of a threat, so if you thought it was a snake, what's happening is that your amygdala, the part of your brain, it bursts into action whenever there's a perception, whether it's real or not, does not matter. Your amygdala has now lit up. It is on fire, and your brain is taking over with the sole purpose of keeping you safe. So when your nervous system reacts, it does not matter if the perception is real or it is not. It doesn't matter. Your nervous system is going to react the same. I love going into this detail here because I think for many years, I think if I were to say to you, well, we've got to fight, flight, and freeze, and you're going to say, oh, I know that. We kind of have an idea of what those things mean, but I want to take a moment and really put this into perspective in terms of things that happen with our residents and with ourselves to put this into better perspective. So when our amygdala goes on, is stimulated, there's something in the environment that says threat, 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 there's a danger. Our nervous system is going to react with a fight, response, flight, or freeze. We lose access to choice at this point. It's not like we say, I perceive a threat. I therefore am going to flee. I am going to fight, or I'm going to freeze. It doesn't work like that. Our biology is created in a way that this reaction happens very, very quickly. So let me put this in perspective. I am pretty sure that if I were to read medical records in your facility, I'm going to find some documentation that says non-compliant or combative. Think about this in terms of a nervous system response. A person could be struggling to regain or hold on to a sense of control, which shows up to us as anger, defensiveness, blaming, arguing, or some kind of actual physical violence or verbal violence. So that person actually could be in a fight response. The flight response could appear to us as staff as resistant or uncooperative to care. And this person could actually be disengaging or withdrawing, which might show up as anxiety, avoidance, denial, or drug or alcohol use, because their nervous system has told them this is their pattern. And we can see that sometimes people tend to one or more of these patterns, that they tend to one over the others. So they could be fleeing. They are simply checking out of the situation. A freeze state might appear as passive or unmotivated. The person could be giving up to those in power. So remember, we talked about power. Staff tend to have more power over residents. So my hope is that as we move more towards trauma-informed care, a partnership paradigm, we level those playing fields of power. So when a person is in a freeze state, it could show up as disconnection, difficulty picking up on their own feelings and their needs, disassociation, or that very flat affect. It's like there's just no one home. The eyes are lifeless in a sense. That person could be in a freeze response. So here's a couple of several clues that your nervous system could be activated. So I envision, how do we teach this to staff? How do we teach them that when they've gone into to support a resident by providing assistance with ADLs or whatever they might be doing? If a person has things like dilated pupils, muscle tension, posture changes, maybe they've gotten very big in their posture, they're very big and almost in that kind of aggressive stance, that could indicate a fight response. When we go into a freeze or shutdown, what you're going to notice more of is you're going to notice a head down with the shoulders kind of crumpled inwards. That tends to indicate a shame response. It could be the person is shutting down, they're freezing, or perhaps fleeing. There's repetitive movements that could indicate some kind of anxiety, like wringing a tissue, tapping, jumping, kind of bouncy kinds of movements, repetitive. Their hands could be shaking. You could see some tremulous expressions of distress. There could be changes in their speech. It could speed up a lot. It could slow way down. They could lose coherence. They could actually be talking in a way that doesn't make sense or that we cannot understand what they're saying. Another really big indication that your nervous system has been activated are changes in breathing. So what would it be like to help our staff and train them to pick up on these clues when the body of another human being is giving them clues, or themselves? When I sense that I'm having breathing changes, my posture changes, my speech changes, that's giving me important clues about what's going on with my body. So these are some of the clues. And why is this important? So let me take it a step further for you here. This is the work of a colleague of mine, a certified trainer for nonviolent communication. And what he talks about is something that made so much sense to me years ago when I heard him teach it. It's called the line of choice. So you'll notice in the middle of this slide, we have this thing called the line of choice. If I am below the line of choice, I am in what's called a reactionary mode. I'm reacting to a stimulus. I'm reacting to a situation. So we just talked about the fight, the flight, and the freeze. Over here, when a nervous system is immobilized, that means there's no movement, they're frozen, which could show up as a sense of helplessness, depression, shame, and shutdown. They are below the line. They are in a reaction mode. The nervous system could also be mobilized. So there's an energy, there's an activation of the nervous system, which could show up as fight, anger, rage, irritation, frustration, arguing, defending, fight response. or a flight response. I'm going to get the heck out of here. There's worry and anxiety, fear, panic. They could literally leave the room or kind of check out. So those are mobilized response. Those are mobilized reactions. So can you imagine if you are working with someone, if you're with a resident or colleague or your partner, your spouse, or your kid, it could be anyone. If you are noticing any of these reactions down here, that person is below the line of choice. Okay, they are going to show up in a way that might be difficult for us to be around. Hence, notice my language. I'm not calling them difficult. I'm saying that the reactions that they show up with might be difficult. If in contrast, if we are above the line of choice, I am now capable of responding to a situation. So when I am above the line of choice, I am calm. I'm calm and connected. I have a sense of being grounded and settled. I have the capacity to have curiosity and openness, especially if I don't agree with you or I'm upset about something. If I can settle my nervous system to where I can choose a response, I am more capable of proceeding with curiosity and wondering, golly, why did this person do what they did? And why did it stimulate this reaction in me? So it's more mindful and in the present. So this can be a very helpful concept as we really step forward to trauma-informed care culture in helping people understand where they are and if they're activated. What that means is if I'm below the line of choice, what that means is you got to slow down. We got to have time for our nervous system to settle in order to have a response and not a reaction. So here's another very helpful concept here. So we've been talking about the nervous system response. So over here in the amygdala part, where in the limbic brain, where the amygdala lives, we have the fight, the flight, the freeze, the stress response. And that's the part of your brain. So remember that slide I just put up a while ago, that when we are triggered, when we are activated, something has happened in the environment that has caused, has stimulated some kind of a reaction in us. Our brain is automatically thinking, am I safe? Am I going to die? Am I going to be okay? And do I matter? Do people want me? So that part of our brain, when that has been activated, we are more than likely going to be below the line in a reactionary mode. That's where our emotions live. On the contrary, in the prefrontal cortex, which is literally the part of your brain that's in front of your brain, in front of your head, when the amygdala is fired up, the prefrontal cortex will shut down. It literally goes offline because all of your energy and attention is going towards keeping you safe. So that's the part, this part of your brain does so many amazing things for us. It's where the capacity and the skill of empathy. Empathy is the ability to really understand another person's experience and to be present with them in that experience. That's where empathy lives. It's where our insight, our emotional regulation, our intuition, our ability to problem solve, all of those key features and functions that live in the prefrontal cortex, those are going to shut down when the amygdala is on fire, when the amygdala is stimulated. So imagine telling someone when they are stimulated, when they are yelling or doing things that you find very difficult to be around, when we tell a person in that state, that activated state, oh, just calm down, or everything's going to be fine, don't worry. What that actually does is the exact opposite effect. It actually will stimulate the nervous system even more because the person is not experiencing empathy. They're not experiencing a sense of trust or safety. They're simply being told to calm down. In other words, your reaction doesn't make sense to me. I'm going to tell you to calm down and to stop it. So what can we do instead? There's two key questions. Number one, how could this behavior, and I went ahead and left that word behavior in, but I want you to start thinking when you see or hear that word behavior, I want you to also be very clear with an intention that it's actually what we're talking about as a reaction. I'm not using the word behavior as a judgment or a label. How could this behavior make sense as a reaction to a past trauma? So again, this is really a lovely question because it really brings on board that universal precautions idea, the intentionality behind considering everything that we see of this person in front of us. There's probably a history of trauma somewhere in there. And even if they don't describe it as traumatic, there's a history of people going through really difficult things in life and having stress in life. We all have had that and will continue to have that. So how could this behavior or reaction make sense? Number two, what might this person need to avoid reliving that trauma in the future? So one of the future sessions in this series, we're going to be talking about the difference between screening and assessment. And so I'll really delve a bit more into number two. And the reason I bring up screening at this point is because when we talk about what might this person need to avoid reliving their trauma, I don't even really need to know exactly what the trauma was, or we don't even need to know at all. What I need to be aware of is the impact of the trauma, the experience on the current presentation, which brings me full circle once again. If you go back and look at part one, and we talked about the delayed response to delayed symptoms of stress, there was a worksheet of 5 different domains. So that's what we can begin looking at to say, oh, could this person be having a reaction? And what do we as staff need to do in order to not stimulate this again? So those are 2 key questions I would love to see integrated into your stand-up, your sit-downs, your IDTs, your whatever meetings that you have in the structure that you have in your community. So with that, I would love to invite you to put into the chat box one little thing that you are taking with you today. And this is also a time we have plenty of time, and we've left time to have some discussion and some questions. So I do see a question. I'll address that in just a moment. So as we're queuing this up to have any sorts of questions or comments or reactions to anything that I've said, what is one little thing that you are taking with you today that might spur something for you to reconsider or to take to your team or just to discuss later? Charles says the line of choice. That's one of the most popular things. I just gave this presentation, a variation of it last week, and that was one of those things that really fascinates people, that I think is a very good visual. Sonia, your question about the F-tag, it was F-tag 699, F-tag 699. That's the trauma-informed care F-tag that we just got. It was last year, right, guys? It was just last year that we got the guidance to surveyors on that one. So a lot more information in there. Okay, so I'm going to take a look here. Same, Hillary, the line of choice is enlightening. Absolutely. Can you imagine, you guys have just had an idea too, if you were to laminate and actually put that on your tables and stimulate discussion around that and incorporate that into your dialogues when you're talking about resident reactions. Dean, I already didn't like using the word minority. Thank you for people of color, but I will now be actively searching for other terms in my daily vocabulary. Fabulous. I'm so delighted that that stimulated you to do that. Thank you. Okay, are there other things that you're taking with you today? And I want to open it up, and Michelle and Nikki, I'm happy to have people unmute and speak into the space if they'd like.
Wonderful. Michelle, do we have any hands raised?
We do not have any hands raised at this time.
Thank you.
Okay, so we've got a little more time here. I'll keep monitoring the chat box. So let me put this up here on the screen. There are some more resources that will be available, and I think we're going to pop them in the chat box. Let me just, Dean, I just want to read Dean's comment here in the chat. Thank you for being an ally for not only people of color, but people who have undergone severe traumatic experience. Training is wonderful. Thank you. I celebrate that because the sole purpose, truly the sole purpose that I do this work that I do is because I want to help support all of you. I believe in my heart that the more that we do to support our staff, each of us, all of us that come to work every day in this field, no matter how we do it and how we show up, if we can create more trauma-informed, person-centered for each of us and all of our staff, I truly believe that will then show up with our residents and patients and families. So is there a link to the image of the light and choice that you had in the presentation? So all of these slides are going to be posted on the Center of Excellence website. So Nikki, if that link is available to put in there or to share with people, but the answer is yes, Charles. So feel free to use these slides in a way that's supportive for you and your community. So absolutely. A few more resources I want to make sure, and I think Michelle will put the link in there. I continually try to find ways to support staff. So what I did is I created, there's 3 resources: person-centered trauma-informed care conversation prompts. So what I did was I really was very proactive. I went through all of the trauma-informed care principles that we talked about. So there was safety and trust and transparency, empowerment, voice and choice, and attention to culture and historical and gender issues. So all 6 of those, I went through and created a bunch of conversation prompts. In other words, questions. So how can we begin to integrate those and really make those principles come alive in the day-to-day point of care operations in a nursing home? That resource is 2 pages. I did another one on trauma-informed touch, which I didn't touch on in this presentation, but I put together a handout on some pointers on how to conceptualize that and how to think about that and train on it. And then also grounding practices. This is something we will be talking about. I believe it's coming up in the 4th session of this series, to talk about when a person is stimulated or activated, so their amygdala is on fire. How do we support that other human being to achieve that sense of groundedness and settling? And these principles can be used for ourselves as well. They can be used for anybody. So these resources will be available to you. And with that, Nikki, I believe I'll turn it over to you.
Thank you so very much, Paige. As always, it is truly our pleasure to have you partner with the center. Your information is so very valuable. Thank you so very much. Oh, we appreciate you. It was wonderful. Thank you, Paige. And to each of you, we thank you for attending today's training. We ask now if you would take the time to complete the post-test evaluation. You will find the QR code on the slide, and the link is placed in the chat for your convenience. Your feedback is important to us. This grant is sponsored by SAMHSA, and they would like to know your feedback as well. So please take a few moments to complete the post-test survey so that we can hear from you. Your guidance allows us to continue to develop trainings to meet your needs. So please complete the post-test survey.